Good evening, Binesh.
Good evening, sir.
Uh, Hey, can you just hold like just I want to say sharing request. You have to let me.
Good evening, sir.
Evening.
email conference icon.
किसने किया
नहीं चला
I can't share it. Where do I share it, Binesh?
It is not.
वो तो अब आधा आधा का पत्ते सभी मांग लेते हैं तो जरा सी दे देना छोटा
अरे अदरक ज्यादा नहीं डाले अदरक ज्यादा नहीं डाले
दो ही बना
Sanjay sir, did you get the option to share?
Yes, now I got it. Is it there?
Yeah, we can see it.
Okay, I'll stop for some. I think we should have a seminar on daily cough rather than anything else.
Sure, sir.
Good evening, Shashira sir. Good evening,
Good
Shashira
evening,
sir.
good evening, good evening. Just good evening.
Good evening, Sanjay. Good evening, Sanjay.
Hi, good evening, sir.
Good
Good
evening.
evening.
Dr. Benish.
Happy New Year, to you, sir. Happy
Good
New
evening,
Year.
sir.
Happy New Year, Happy New Year.
Yes,
Happy
everyone.
New Year.
So, how many resolutions have fallen by in the last 7 years, 7 days? That I'll sleep on time, I'll do an exercise, I'll go to the gym, I'll just not eat sugar, so many eggs a week.
I think we are in time. Let's just.
Yeah. Time.
Nehas, good evening.
Good evening, sir. Good evening, sir.
Good evening.
Good evening. Good evening, Manish.
Good evening.
Good evening, sir.
Jose, have you read the article by Kamappa in Madharbhumi?
ഇല്ല സാറേ
You
എന്ന്
should
വന്നാ
read that article regarding the invasion of, investors to healthcare facility in Kerala.
അത് എന്ന് വന്നായിരുന്നു സാറേ കഴിഞ്ഞ
Today's article.
കഴിഞ്ഞ ദിവസം ഞാൻ ഇതിനകത്ത് ബിസിനസ് ന്യൂസില് ഞാൻ അതിനകത്ത് വായിച്ചു ഇൻവെസ്റ്റ്മെന്റ് ഇൻ ദ ഹെൽത്ത് സെക്ടർ ഇൻ കേരള എന്ന് പറഞ്ഞൊരു ആർട്ടിക്കിൾ ഞാൻ വായിച്ചു ബ്യൂട്ടിഫുൾ ആർട്ടിക്കിൾ ബിസിനസിന്റെ
extensively covered, not to harm anybody, but to protect the interests of the state.
Yeah.
And that's the reason, because how many can afford?
Nice.
That's the thing.
So can someone tell me the story? What happened?
Sanjay sir, you are working where? Actually, you are working.
I'm working in Gurgaon, sir. Like I'm working in a motherhood hospital in Gurgaon.
Motherhood.
Yes.
Kids head. Okay.
Sir, we'll start, sir.
Yeah, I think we should start the proceedings. The people are joined. Joseph,
Sir, mute on, sir.
We can start at 20 10 അല്ലേ
This time. This time.
എനിക്കൊന്ന് in time അല്ലേ we can start, no problem.
So, respected President, Dr. Jose, senior teachers, my dear friends. So, here we are continuing with the Neonatology talk series. Again, I need to thank and congratulate the team behind working, Dr. Binesh, Dr. Lins, and all others who's working behind this presidential action plan. I take this opportunity to welcome our dear President, Dr. Jose sir. Today's speaker, Sanjay Vasi sir. Sir is the senior neonatologist and medical director, Motherhood Hospitals. I also welcome Dr. Shashidharan sir. Sir is very close to us and very senior neonatologist, one of the first neonatologists in Kerala. Sir is presently working as senior consultant in neonatology and pediatrics at BMH Hospital, Kozhikode, and is a former professor and head of pediatrics Government Medical College, Kozhikode. All other seniors who have been joined here, colleagues and friends, I welcome all of you to this meeting. I'm not taking too much time. I'm inviting Dr. Jose sir for the presidential address.
Thank you, Dr. Nihas. Nihas is audible? Audible.
Yes, sir.
Sorry.
Sir, audible, sir.
So, good evening and happy new year to all of you. Our respected teacher of teacher, Dr. Shashiran sir. Today, the leading faculty, Dr. Sanjay Vasir from Gurgaon. Our faculty, Dr. Nihas, treasurer, Dr. Abi, and senior faculty, senior members like the Varmaji, Dr. P.R. Jayagumar, and all the senior members for joining here. And today, esteemed delegates from the Neonatology talk series on program on acute kidney injuries in newborns. Today, we have fortune to have the Dawn of the Neonatology, Dr. Shashiran sir is here. Agreed to chair this section. In his all the busy schedule, he agreed our invitation to chair over the important neonatal talk series today, the acute kidney injury in newborns, how we can prevent and the management part is concerned. And thank you, sir, for your presence and blessing for our neonatal talk series. And congratulations to Dr. Binish, Lins, Jidin, Srikanth, George, and our secretary and Dr. Rashar, taken all the initiative to coordinate this neonatal talk series in an excellent manner. As you know, today the topic is very important for our day-to-day practice is concerned. The kidney injury, acute kidney injury is a very important, it's a significant and growing concern associated with high morbidity and mortality and long-term venous sequelae is concerned. As you know, the fragile physiology of newborn, especially preterm babies, make them highly susceptible to kidney injury due to various factors like hypoxia, sepsis, and the medication itself. With advance in neonatal care, more babies are surviving in a critical illnesses, but acute kidney injury remains a major challenge, impacting the short-term and long-term sequelae. Today, we have an expert in the field, Dr. Sanjay Vasir, here to update regarding the recent update and how it can prevent in the neonatal ICU and how it can be tackled if the child go into an acute kidney injury is concerned. I think this program will be enlightening all of you regarding the knowledge regarding acute kidney injury and it is management part is concerned. Thank you, Sanjay, very well for your accepting our invitation and take part of our neonatal talk series. And again, I wish all the best program. Jai Hind, Jai NNF. Over to Dr. Nigas for further proceedings.
Now I request Dr. Binesh to start with the proceedings and invite Dr. Shashidan sir for the. Binesh, please take over.
so Good evening, everyone. So, it is my pleasure to introduce our speaker, Dr. Sanjay Vasi sir, a distinguished neonatologist with an MD in pediatrics and DM in neonatology from PGMI Chandigarh. He is currently the director of NICU at Motherhood Hospital, Gurgaon, with over 18 years of experience in neonatal care. Dr. Vasi's key areas of expertise include neonatal ventilation, perinatal asphyxia, and acute kidney injury. He has an impressive academic record with 37 index publications, over 30 book chapters, and is the author of well-known book on hypoxic ischemic encephalopathy. He has also served in several leadership roles within NNF and IAP, contributing significantly to academic and professional development. On a personal note, Dr. Wazir is my senior, and for many youngsters like us, he is a role model and mentor, and it's a privilege for me to introduce him today. So, please, sir, over to you.
Thank you, Banesh and Dr. For inviting me over. And just a caveat on busy schedule, because since last year when I was working with Manoj, he told me that whatever be your busy schedule, it has to end at 7:30. Rest should be like free. So that's like, and in fact, like something like there is a lot to learn. And in fact, last year I was there with Manoj in this lifestyle workshop. There he said, everything, even your learning, should stop at 9 o'clock. So I'll try to finish it well in before that time. Can you share my slides now?
Let's get over with this.
So can we see that?
Yes, sir, we can see it.
Okay. Now, so let me start with the talk first. We're talking today about prevention and prediction of neonatal AKI. And thankfully, this topic is now gathering attention across various conferences. Earlier, it was thought of that like an organ which just produces urine. Why bother it? I mean, if it produces it, well and good. If it doesn't, we'll find a ways to get the urine out. And that was the importance. Still, a lot of research in adult kidney diseases came across that the lifetime determinant of your lifespan is one of the three organs, apart from other heart and brain, that we've always been talking about, is the adult kidney. Now, if you look at these two, images with me, the Lotus Temple in Delhi and the ancient Meenakshi Temple in Madurai. So, what do these architectural marvels teach us about kidneys and AKI? Now, first, it is the complexity and the beauty, and just like these intricate structures, the neonatal kidney is a marvel of biological engineering, as Dr. Jose was just mentioning a little while ago. And more importantly, there is a need to protect these monuments with constant vigilance. So neonatal kidney requires our protection during the most vulnerable period. And third, more importantly, the foundation matters. Just as these buildings are standing on a carefully constructed foundation, kidney health in the adult life is based on what happens to them in the neonatal periods just after they are born. So we need to prevent this damage. Once the damage is done, there is little that we can do to correct it completely, but we can only prevent further damage. So it is important that how do we prevent damage before it is too late in the day for the kidneys to get revived. Now, as far as the definition is concerned, we start with the usual. You see, there are so many classification systems which have come derived mainly from adults or children on the pre-rifle criteria, the AK and the KIT curve. But most of these were not even designed for newborns, because newborns have that unique physiology. They're urine output is gestation based sometimes, and it also time based. They may not even start urinating on day one itself immediately. Hello, can I go ahead?
Sure, sir.
Okay. So 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 that like the creatinine level, the so-called baseline creatinine level, they initially reflect the maternal levels, and as I said, the urine output patterns vary dramatically according to the gestational age and also the postnatal age. And what most people and scientists and nephrologists like reached a consensus on defining by modifying these Kitko criteria, and like I just mentioned for this, the stages. I'm not going to go in detail because this is well written in the book. But despite this, intricate classification system, one must remember that we still underestimate or miss 20% of AKIs, and that's why there is a growing concern among nephrologists and neonatologists to look at biomarkers if we can like combine with some of the clinical criteria. But what is essential that we're missing still, despite the most stringent criteria, 20% of the AKIs. Our we did one study which was a awaken study, which was a study which was done across 13 centers, 11 in US, one in Argentina, and one was India, because they also wanted to include some developing part of the world. So that collaborative, we saw, when we saw these results, it was sobering. Like the AKI mortality was nearly threefold, and there were 7 additional days of hospitalization, and this is all after adjusting for other factors and confounding factors. But on the right side, if you see, that is what bothers us more, the long-term data. Although this was not from our group, there were 8 longitudinal studies which following these babies from 1978 to 2014, and they found that among the children who had neonatal AKI, the rates of chronic kidney disease in survivors was almost to the tune of 66%, which means two-thirds, and we're not talking about acute illness, we're talking about programming a lifetime of renal dysfunction. Two-thirds of those who have severe AKI in the newborn period would end up with some renal dysfunction later in life. And one of the takeaways from this study, from this talk, I want you to take is that we generally recommend, and we're going to come up with the guidelines along with the Indian Nephrology Group in some time, maybe this year, mid, that we recommend that all survivors who have had like stage 2 or stage 3 AKI need to be annually screened for hypertension and albuminuria, much like the diabetic population and adults who look for microalbuminuria. We need to look at these two parameters, and a serum creatinine which is greater than 0.6 at 1 year, or a urine protein creatinine ratio of 0.6. These are our red flags. And a BMI which is more than 85% at 3 years further compounds and increases the risk of a chronic kidney disease, and we need to be really nephroprotective in this subgroup of patients, at least if not all, who have suffered AKI in Kitko stage 2 and 3 initially. Now, I'm sure you would have probably heard of this, the cannery in the I think all of you have said this cannery in the coal mine story. In the earlier time when there were no better detection methods, they would take the cannery bird into the coal mine. It could sniff the toxic gases faster than humans. So if the cannery would get sick or died, there was time for humans to evacuate the place, and then they would evacuate the place before the toxic gas is spread. Now, in the same corollary, this neonatal kidney not only reflects the injury to the kidneys, the AKI also reflects injury to the other organs, and it just acts as a marker of a systemic illness. When it comes to, say, for example, those with an AKI have an increased risk of having an IVH. I'm talking for preterm babies, abnormal MRI as well. The AKI during during the those with an HI If you do it, like there is an increased risk of abnormal MRI compared to the babies who have HI and no AKI. In the AKI, in HI, there is like a worse a death or a disability, which is higher in the group which had an AKI compared to the non-AKI group, and among the babies who are preterm 29 to 32 weeks. And these are some of the studies that I published, about the cross connection between other organs. So what it means that, like, that these associations tell us that we see AKI, but we often seeing a sicker baby with a multi-organ dysfunction, and that is why it is important for us to predict which babies are going to have an AKI. With that in mind, as I said, we had a collaborative meeting with people in US and Argentina and India, and we set up our first retrospective analysis of around 4,000 babies who were in NICU and whose records were available for us, and we published our first study in Lancet 2017 on 2,000 odd babies. And what was fascinating, or probably depressing to say, was that 30% incidence of AKI was seen in babies who were admitted into the NICU for reasons other than the usual TTN and the jaundice and other things. But those who were really sick required IV fluids for 48 hours for one or the other reason were the inclusion criteria. And what we saw, according to the bifurcation also, that nearly the incidence varies according to the gestational age. For obvious reasons, the children who were in the 22 to 29 weeks gestation, there almost half of those babies had an AKI. 29 to 36 weeks surprisingly had less AKI compared to term babies who were more than 36 weeks. Almost one third of the babies had AKI, and that is not difficult to understand because although we did not look at individual babies in that category, but our hypothesis was that only the sicker term babies get admitted to NICU. The babies in the 29 to 36 weeks babies are generally those who are relatively well-fed babies or relatively stable babies and may not have major problems. So that is why they were less represented in the AKI. But overall, it was 30% incidence in our group. So we let me introduce you to another concept called prediction. So in a renal angina index is a risk stratification tool for an early prediction of severe AKI in children admitted to PICU. And those children who have a renal angina score more than 8 are more likely to develop severe AKI, require renal replacement therapy, have longer PICU stays, and also increase mortality. So with that intention in mind, that we will need to, because the last study, as I said, Awaken, although it was published in Lancet, but it was still a retrospective study, and people had their own reservations about whether we are able to predict in future from a retrospective study alone. So with that, we developed a online registry, the world's first online prospective registry for neonatal AKI. And I thank my colleagues Siddharth, Rupesh in US, Gopal here, Binesh was part of the team who were, and we looked at 11 centers across initially. We approached 21, but eventually 11 were continuously giving us the data. And we wanted to collect the real world outcomes across multiple centers, and we purposefully did not choose randomized controlled trial because that does not really reflect how we do in the real world. So we wanted to collect a real world data, and based on this, the study, we also got a AKI incidence in Indian population also around 30%. However, and there was a higher mortality risk. However, the length of stay was not different, and our hypothesis is that most of these babies were those who really get sick, some of the centers tend to, like, either the parents want to take them Lama, or whatever reason they get transferred out for one or the other reason. So the length of stay between the sicker and the non-sicker was not different, for probably for more discharge reasons. So this brings me to the STAR score, and I have to tell you, developing this tool was one of the most rewarding projects of my career. And the STAR acronym stands for 5 people who were involved in the generation of the score, and they're all been mentioned in the top as authors, as I said. So the star scores is when we come into scoring, so it was we assigned points based on timing of the NICU admission, whether the PP was needed, the gestational age categories, the presence of sepsis or cardiac disease, the urine output in first 12 hours, the baseline creatinine, and exposure to nephrotoxic drugs. And based on this, we stratified children on the risk for the AKI. And what it came out to be that based on the multiple regression, logistic regression, we found out that, like, a score which was less than 31.5 almost had a 80% positive predictive value and a negative predictive value of around 95.6%. What does it mean practically? It means that if your score is less than 31.5, you can be almost 95% confident that the baby would not develop AKI. And that's that is powerful for resource allocation and also for monitoring intensity, because we're always short of resources, both manual and equipment wise, in our NICUs. And one of my favorite features was the urine output less than 1.4. I'm going to come to this in just a slide later. Now, the proof of pudding is in eating. So what we do is, like any prediction tool, is as good at its validation. So Dr. Gurdeep from Ludhiana, DMC Ludhiana, did an independent study, which was not part of this, but we were part of the analysis group. So, so did it as a part of a thesis for one of his students over 3 years, I guess. He did. And we published that, on almost 1400 babies were screened, out of which 797 were enrolled, and the area under the ROC curve was 0.95, and that is an excellent discrimination. And that also, the negative predictive yield was 98.9%. So here is what it means for your NICU. So when you calculate a STAR score in the first hours of life, if it is low, you can be confidently reassure the parents and adjust your monitoring. When it is high, it is time for you to activate your nephroprotective protocols immediately. Come to the urine output, and there are 3 different research groups, 3 different thresholds, all pointing to the same conclusion, that early oliguria predicts AKI. In our STAR study, we said that less than 1.32 ml per kg per hour in the first 12 hours. Others found 1.5 ml per kg per hour, or another one said less than 2 ml per kg per hour. Now, here's my practical advice. If you see a urine dropping less than 1.5 ml per kg per hour, if the child is on an IV fluids, do not wait. The typical teaching that 1 ml per kg is the urine output is based on some pediatric and some adult data, which has been extrapolated and never be validated. So the current basis of the study is that less than, in our unit, anything which goes less than 1.5, we tend to get a little worried about what is happening to the fluid balance, what is happening to the kidneys, are we causing more damage. So for us, the criteria is 1.5 now. Many centers in our countries do not have either the expertise or the equipment to do a peritoneal dialysis. So what should be done to these babies and how do we identify them? So our idea was that among the babies we had in our cohort, can we find which babies would require dialysis? So we found applied this star score, and we found that a score of less than more than 59 had a sensitivity of 71% with a specificity of 70% to detect the babies who would have a severe AKI. But if the score crossed 66, almost sensitivity was 97% for you to do require peritoneal dialysis. Now what does it teach us? It teaches that, like, when you have a very high score, it may be time for you to get your PD catheters ready. It may be time for you to involve your nephrology friend and also counsel the parents for outcomes, because as we discussed earlier, 3 times the higher mortality. So you need to be sensitive about what you're going to tell them about in the long run. Let's discuss about some of the emerging markers we usually measure commonly otherwise also. So among the first is an albumin, and data from the Awaken study group, and our team found that the low albumin levels were independently associated with both early and late AKI. And for every 0.1 gram per deciliter decrease in albumin, increase the odds of late AKI by almost 12% on continuous analysis. And we don't know whether correcting hypoalbuminemia prevents AKI, but it's a marker of increased risk. So I'm not suggesting that if you have a low albumin, you need to go and correct to protect the kidneys. You need to increase the albumin, because some of the ways people have looked at an albumin and found that low albumin is a marker of increased severity of the disease. So probably we are just connecting the two dots, hypoalbuminemia and a severe child, and presenting as AKI, but that was an association. We found that low hemoglobin levels were also associated with an increased risk, but the catch was that after controlling for the fluid balance, the association disappeared, which tells us that, like, probably hemoglobin levels are confounded by hydration status, and we need to think about the whole picture, the fluid balance, the hematocrit, and the urine output put together. Now, another tool that we generally use is, like, when you have a child with a neonatal AKI or even pediatric AKI, we tend to use furosemide very commonly. And in our Tinker database, when we had 600 babies initially, were less than 28 days and received IV fluids for 48 hours, which were our inclusion criteria. Furosemide was used in almost 9% babies for fluid overload, oliguria, AKI, cardiac disease, whatever, reasons, because we had not looked at why they are using it. But what we found was that this furosemide increased the mortality. The survival was significantly worse with furosemide, according to the Kaplan-Meier curve. Now, we understand that, when you have an oligonucleotide failure, you end up using furosemide, and based on this 600 babies, we are not saying that furosemide definitely causes, because it will be too premature for us to conclude that. But what it tells us that if you have to use it repeatedly, probably, should not be done. So my take-home message is that furosemide is not benign. If you have to use it once, use it judiciously and for the shorter duration which is necessary, because increased used as in adult studies has and pediatric studies have shown that it does not change the outcome and in our case it made the survival worse. Now, our civilization and Indian architecture has laid a lot of stress on preservation, and if you look at the step wells which were designed even in deserts, they were able to hold water for the longest period of time, and throughout the year the water was available in the step wells, because the evaporation did not happen as usually. The water would get collected in the rainy months and would store under ground. So what I meant was that, like, in kidneys also we need to use a lot of preservation rather than say, okay, once the damage is done, once the water is evaporated, can we get it back? So among the prevention, the important thing is that we need to look at how we are judicially using a nephrotoxic, preventing a nephrotoxic injury. Now, if you look at this study, which was done in University of Alabama, and was one of the seniors from PJ only, Dr. Amlavanan, and he did a baby ninja study, which was nephrotoxic injury negated by just-in-time action. And I love this program because it's elegant. It was elegant, simple, and it worked. And what they did was the daily screening of infants exposed to more than 3 nephrotoxic medicines or more than 4 days of IV aminoglycoside, which often is the case in our NICUs. We start with Ampigenta, and Genta goes on for 7 days minimum. And they recommended daily creatinine monitoring for at-risk infants, which were these babies, for during and 2 days later after the exposure ended. Now the results were very, gratifying. Is that the nephrotoxic, when the people in the unit got scared of like doing a daily creatinine, looking at the creatinine, the use of nephrotoxic medication exposure decreased by 42%, and the AKI prevalence decreased by 78% within the 18 months of the program, and the sustainability reductions maintained through 2022, and that kept on going. So the key innovation in this case was combining education, EHR records, standardized creatinine monitoring, and nephrotoxic medicine avoidance when possible can lead to protecting these injuries in the long run. For prevention, for protection, we also have a strategy which probably you already use it, but may not be thinking it about from the kidney protection, which is the caffeine. So we analyzed as a part of an Awaken group 675 preterm infants, and we looked at the AKI free survivals. And if you look at the Kaplan-Meier curve on the right side, the caffeine group had better AKI-free survival over the first 7 days. So caffeine in the first 7 days reduced the risk of late AKI by 80%. And among those with an early AKI, the caffeine reduced the progression from stage 2 or stage 3 by 80% as well. And the practical number is that for every 4.3 neonates who are exposed to caffeine prevents 1 case of AKI. The mechanism could be adenosine receptor antagonism, improved renal blood flow, anti-inflammatory, whatever, but regardless of the mechanism, the clinical benefit is clear. So when we say, okay, should this baby require, caffeine? Now, from an apnea point of view, yes, there people could be having a debate, but if the child is ventilated, some people say, okay, if it's already ventilated, there's no apnea, so can we avoid? So the consensus is that we should use caffeine as early as possible, both for the respiratory benefits, the PDA prevention, and for the kidneys. So there's a win-win with this kind of a silver bullet, and I do not think any preterm babies in this scenario, especially less than 34, we should not get a benefit of caffeine in current era neonatology. Now, one of the other things that was the last I want to present was the use of theophylline. And when I joined my residency, that time one of my seniors, Sanjeev Rath, was doing his thesis on theophylline and AKI. And there have been 2 of my other friends who have done this, meta-analysis. Both Rashmi Ranjan Das and Akash Pandita is also a neonatologist in Lucknow, and both the meta-analysis showed that the use of theophylline to the tune of 5 to 8 milligram per kg is associated with 60% reduction in severe kidney dysfunction in severe birth asphyxia. Okay. Okay, and the kidney, but the kidco the Kidney Disease Improving Global Outcomes group, they published a clinical practice guidelines supporting the use of theophylline in severe AKI. Despite this, we as neonatologists are wary of using theophylline because we always talk about we do not know what's happening in the long term kidney and what happens to neurodevelopment because there are no studies on theophylline and long term outcome, and there is a potentially interfering role with hypothermia now that we're using it for HIE because we need more data there. What happens when you use theophylline in hypothermia? But my practice, consider that therapeutic hypothermia is unfortunately still not available to almost 80% of the children who have babies with HIE. The most of the HIE happens, and since we are doing the ENICU across different regions in the peripheral areas, we found that 50% of babies have who come and get admitted, not 50, sorry, 30% of the babies who come to get admitted have HIE, and in those babies, like when you do say for example the renal dysfunction, they are very impossible to manage. So those babies where we do not have a facility for a peritoneal dialysis like routine monitoring, or there is no hypothermia, it based on this evidence it may still be sensible to do one dose of theophylline, and if we can prevent an AKI, we would have averted an acute oligouric renal failure going into say the baby going into the oligouric renal failure. So so towards the end, if I have 1 minute more to summarize, the neonatal AKI is much more common than we think, affecting 30% of critically ill newborns, more than the PDA, which we talk about in every conference, much more than the either use of surfactant these days, and the impact is also long term. Almost 66% of the CKD plus the neurodevelopmental concerns we just talked about a little while ago. And third is that the prevention is possible through Baby Ninja, through caffeine, theophylline, and more importantly, avoiding nephrotoxins. And fourth, that timely prediction helps us identify at-risk babies before injury occurs. And stars score, and again, I put my gratitude to Siddharth, Rupesh, Gopal, and Abhishek for doing this, and urine monitoring. So what we see here is where we started. We come back. The Taj Mahal took almost 22 years to build and has now stood for 400 years, just because the Emperor Shah Jahan at that time was obsessed with getting the foundation right. And as neonatologists, we have a similar opportunity with neonatal kidneys. The foundation for lifelong renal health is laid in NICUs for those children who have to be in NICU for whatever reason. So we can't prevent every case of AKI, just like we cannot prevent every storm that threatens these monuments, but we can predict, protect, and preserve the neonatal kidneys and plan for the long-term follow-up. So neonatal kidney is an architectural marvel in miniature, less protected. And the key points that I would probably just take you through, and actionable ones, which I want you to go through this still. One is that you can apply the STAR score to at least know which way the kidneys are going to behave. You probably can look at a urine output and keep it closer to 1.5 rather than 1. And third, that you probably would reduce the use of nephrotoxic drugs by doing an active creatinine surveillance. It will reduce, even if you do nothing, it will reduce your risk of AKI in the NICU. And the fourth, I said in the follow-up, you probably should monitor and look for those who have a stage 2, stage 3 kidney according to the modified KidCo guidelines. They should at least go back and have an annual checkup to prevent their long-term kidneys from failing early. Thank you so much, and if I'm happy to take any questions regarding this.
Thank you, sir. Thank you so much for that enlightening presentation, and especially for sharing the original data. And let me just ask our chairperson, Shastran sir, for his comments. Further. Shastran sir, please unmute yourself. Sir, you are muted. Sir, please unmute.
Sir, sir, unmute, sir. You're muted, sir. Please unmute, sir.
Okay.
Yeah, okay, sir.
Can you
Okay.
hear now?
Yes.
Okay. Now, again, once again, I thank you, Dr. Sanjay, for an excellent talk. And I'm interested to put a question to you. When an isolated AKI comes alone, or if it comes in combination with other multi-system involvements, the strategy becomes really tough. And as you rightly mentioned about use of various nephrotoxic drugs and other drugs that can interfere with the safe or protection of the kidney in the neonates. What is your comment on that?
I didn't get the question right, sir. Can you just please say it again, like, for a minute?
Again, multi-system involvement.
Yes.
And with kidney, with AKI,
Yeah.
the strategy for managing is certainly going to be really tough. And the
Of course.
drugs that use may sometimes contain nephrotoxic drugs too.
Correct.
So to take, extra precaution on this issue, you have already mentioned about using some of the drugs. You said don't use diuretics like furosemide and such things. So this message has to go down in the system so that people don't use nephrotoxic drugs in managing this multi-system cases. And what is your comment on this?
I agree with you completely, because when the newborn starts to deteriorate, our thinking process deteriorates faster. So we end
Yes.
up like like reacting immediately and expecting miracles to sepsis, suppose SIRS in a newborn, like a inflammatory response because of sepsis. It will not improve in 6 hours. So every 6 hours, I see many times people getting, or when now we need to use meropenem. If it is not improving, what to do? Ceftaz AV, and then TG cycline, and then so host of this thing, without realizing that if you have trusted one medicine, then at least trust him for at least 12 to 24 hours. Give him some time to act and then see, or your decision is wrong in the first place. But we understand this is human for us to really ramp up the medication. But the basic message that would you put across forward, that are we causing more harm by doing this? And so we need to assess our risk benefit ratio, that if I do it, like say for example, am I using furosemide multiple times? Am I trying to console myself and say, okay, I've tried enough, or I have done like enough damage, like by my interventions? So this is a call that I'm sure as neonatologists we are getting wiser, and we understand that most of the times the absence of neonatologists in the NICU sometimes brings better results. At least my sisters say, though, don't come to the NICU.
Thank you so much. Thank you so much.
So there are a few questions
Yeah.
is in comment box. So one is the prediction of AKI, neonatal AKI based on novel biomarkers. So what's your comment on it, and which one to use if they're available? Like maybe the NGAL, cystatin C, or something like that. So
Yeah, so basically, there are novel biomarkers which are traditional biomarkers like serum creatinine. We said that there is a problem with the serum creatinine reflecting the maternal values, the value change in the first week of life, and so there and 20% under detection rate with this thing. So people are kind of looking at, can we look at other biomarkers like NGAL, for example? You said like there is TIMP, there is like insulin like growth factors, there are multiple others. But with different studies also, the combination yield is around, sorry, exceeding 0.8%, which is good. But the problem is like, doing a study like this, we thought of doing an NGAL with this, with the clinical criteria. The, the cost of doing that study is like very expensive, and it would have costed around 3 lakhs only to do it among couple of babies to do that study. The other problem is that when you send such a study, like the results are not instantly available in Indian scenario. So although it can identify the babies who AKI subgroups, long-term GFI decline risk, but I mean, for acute management, it may not be of value, at least in the current era where they need to be sent to the lab and analyzed in day or two coming back by the time the decision would have already been taken.
So just an extension of that question. So we are bound to use serum creatinine and urine output for routine monitoring in most of the settings. So again, the question is when to start monitoring serum creatinine, especially in the first 24 hour. It may not, if first 24 to 72 hour, it may reflect the maternal status as well. So when should we take the serum creatinine seriously in a newborn? In other ways, a good looking newborn or in a sick newborn, and how frequently should we monitor it especially in a child with NACU ridden or sick child?
So the question about like, when should we, because based on the KidGo guidelines, because most of our staging and other things happen on stage 1, stage 2, stage 3, is where is our reference or a baseline criteria, and whether we see, say, for example, stage 1 is more than 0.3 milligram deciliter above the previous value within the 48 hours, okay, or it is more than 1.5 to 2 times the reference serum creatinine within the first 7 days. Now, the question is, when do we do it? So we generally say any child who is sick enough to require other labs would also qualify for doing a serum creatinine at that point of time. We take that's a worse or a bad, and that's a problem, but we still take it at that time. In the babies who are not well, who are well and otherwise do not have a problem, we do it on day 3, primarily because with the child we have had time to undergo some kind of an damage, if at all, if it is there. If not, that would reflect the baseline value, and then we take it based on that kind of a value. So sick child, anytime when you're doing a test, even in the first 24 hours you're doing it, and a non-sick child after 48 to 72 hours.
So again, in one of the slides you showed that the urine output of less than 1.32 or less than 1.5 in the first 12 hours of life, in the first 12 hours, has got a significant prediction towards acute kidney injury. So, but the problem is that in many of the well-looking newborns, in the first day of the life, the urine maybe many of us, especially in the RDS baby, the urine will be or many of often it will be less than 1.5. So should we worried about, or should we routinely check renal functions in these babies on day 3, day 4?
See, truly speaking, yes, we do. Although again, when you say, okay, you are basing your assumption based on a a prospective collected registry. It is not a controlled trial where we can say, okay, 1.5 versus 1, what is the outcome difference? But when we looked at this literature from other studies also, most of the people now feel that 1 may just be barely enough. So we do not say that you start intervening if your blood, goes and you start pushing boluses because your urine output is 1.2 ml per kg per hour, for example. But we are saying get cautious. Do not wait for it to fall. So the same alarm system that you put after 1 ml per kg, if your baby's urine output is 0.6 ml per kg per hour on suppose day 2 or day 1, and the child is on a ventilator and has, would you get worried? For sure you will get worried. We're saying, okay, just increase the threshold from 1 to 1.5, but does it mean that intervention needs to be done? You need to push in bolus, give furosemide? No. I mean, there's no direct answer that we got from our studies, and we've not looked at whether that intervention is the right approach. but look at whether you're using a nephrotoxic drugs. Are you underhydrating the child? Are you probably dealing with a PDA or something else happening? But just monitor, because this may be a simplest tool in the peripheral areas to look at rather than waiting for it to fall till one.
Another question that is from Dr. Anand. Sir, can you guide on the use of serum creatinine value cutoff, which is gestation wise, especially for preterm babies?
So that, as I said, like we have graphs available for age gestation. So probably after this, I can share it with Binesh and he'll share it with you. Like, but what I recommend, see, graphs are good, normograms, but they're not really are helpful because a child may behave differently. But what as a doctor we are interested is that a value which is increasing or decreasing has a trend is more valuable than an absolute number. So if you're going for a study, I can understand, I can share those charts with you, and those are available on the net also. But for practical purposes and for KidGo guidelines purpose, you need to just look at a increase or decrease. So you've done it one, and you do it after a day or two again, depending upon the sickness level, and you see if it is a progression. I know this is a child who's going towards AKI, even if both the values are less than the cutoff for that particular day. So if it is somebody who was zero point 0.3 now and 0.7 now, second day, even if it is less than 1, which is the cutoff for say 27 weeks on day 1, I would still get really concerned whether this is going to a stage 1 AKI rather than waiting for it to cross.
Again, sir, the in the baby ninja study which you mentioned, it showed around 75% reduction in the AKI.
Correct.
So what exactly made that difference? So people just got aware or more concerned about nephrotic medication and decrease the use of nephrotic medication, or
Yes, because the use decreased by 42%, 40 or 42%. I exactly don't remember, but then it was almost more than 40% reduction in the use of a nephrotoxic drugs, and that's what we tend to, as Doctor was saying in the morning, in the beginning right now, that we tend to overdo when we have a sick child, and once we are sure that what we're looking at is causing more damage and we're serious about it, we found that, like, they started monitoring the serum creatinine, and that sensitized the whole unit. So a continuous education about nephrotoxicity and monitoring led to almost 70%, 78% decrease in the AKI by use, by 40% lesser nephrotoxic use.
that's actually a great eye opener, because in many of the Indian setup, we don't even think about neonatal kidney injury unless otherwise baby goes into oliguria. So
I don't
just
think I think 50% of the babies who got out of in Indian NICUs. I mean, I'm not saying Kerala is an exception. So because your NMR is like puts everybody else to shame. But I mean, in my part of the world, and when I do the ENICU, I see cholesterol is the second commonest drug which is used, and it's like after that later is second, and it's like so it goes so rampantly that nephrotoxic drug usage is very, very common.
thank you, sir. Thanks a lot. Dr. Nihas and Dr. Lins, any other questions? Dr. Nihas, are you there?
Hello, sir. Hello, sir. I myself, Dr. Lins. And this use of, I think, the use of furosemide in AK, I think it is a really controversial topic. I think almost 70 to 80% of the units I feel after a fluid bolus, their reflex will be to start a furosemide infusion, say 0.05 to zero point 0.1 milligram per kg per hour. So I think this thing is also a real eye opener, I say.
Yeah, it's like so. What I'm saying is that we do not have a conclusive evidence that furosemide is bad. But if you look at a pediatric literature, if you look at an adult literature, for there is enough data to suggest that furosemide does not change the outcome. Much like the low dose dopamine, which was used at one time as a renoprotective, and that has gone out of favor. Now, what is interesting, because some analysis from our paper shows that furosemide may be actually harmful. Like, so you could possibly use one, but if you keep relying on furosemide to do the trick, what has been damaged by nephrotoxic medicine, I don't think that's a right strategy. So one, maybe yes, but if you don't see response, please don't continue.
So just one more question from the because we know that the creatinine has got its own problem. So should whenever a baby has got some AKI, should we do routinely a ultrasound KUB to detect? So ultrasound has got any other unless otherwise other than picking up congenital malformations. Do it have any other role in predicting the AKI or managing it?
Purely from like in the neonatal space, I mean, there is no prediction which will be beneficial, but any child with an AKI, you want to rule out an obstructive uropathy at any case. Like, so first, thing is that you need to look at an ultrasound. It will give you whether there is an obstruction. There is a CACUT, as you said, like, any congenital abnormality. You would also look at like the bladder, like I mean, scan workshops are meant to look at if bladder is full or not, and we are overthinking, overdoing it not. And once we look at one more thing, sorry, is to look at a renal vein thrombosis, because many times, like, LJ babies, term babies, that like one of the causes of, increased kidney. But the typical, which we generally, the ultrasonologists are kind of they favor writing is, there is loss of corticomedullary, differentiation. So
Yes.
so I feel okay, there is a loss of differentiation in the clinician and the sonologist, because that cannot be resolved and has no value. But that's the most common kind of writing there.
I have to put a question to Dr. Sanjay.
Yes, sir.
Would you recommend a revision or a rethinking on the fixed drug combination as ampicillin gentamicin routinely used in most of the nurseries?
You mean to say, should we use it or not use it?
No. The question is, you have to revise it, isn't it? Because we are very much concerned about the nephrotoxicity.
Correct. Yeah.
Isn't it? Blindly used. The price, as you said, by looking at your data and the way you present it, it's really alarming. We were inadvertently using this combination.
Correct.
But that has to be, I mean, we should have a look at it, rethink it, and try
100%,
to revise it.
100%, sir. I mean, see, if you read any textbook, right, which you have been we reading from the times, like from the MD times, the Nelson also
Yes.
says, okay, if you're using aminoglycoside, get the trough levels.
Yes.
Like, we understand that there is, because nephrotoxicity was a concern that time and now also, and that why as NNF and as neonatologists we say that, your every drug that you're putting into the baby like has an implication. So think of a harm first that you're causing, and then think of a benefit that you are creating. If the harm is there, just think of how fast you can get rid of the drug in the first place itself. Like, and we know among this, like, ampicillin gentamicin is known to cause nephrotoxicity, a little bit of phototoxicity,
Yes.
which is like
Yes.
again.
Thank you. Thank you.
Dr. Links, if there is anything to add, or should we conclude?
I think there is no more questions, I feel. And we can just conclude it, right? I think there is no more questions, I think.
Joseph, yes.
Dr. Nihas, Dr. Nihas?
Nihas?
So so I guess I invite Dr. Links for the vote of thanks, and then I think we can conclude it.
Thank you.
So,
Thank you so much.
thank you.
Thank you.
thank you, Dr. Sanjay Vasir, for that elaborate session on AKI and on the recent updates, especially in the management of AKI. And it was a really enlightening talk. Thank you, Shashidharan sir, for joining us and moderating this session and giving your valuable inputs. Thank you, Dr. Binesh, for this organizing this session and conducting this program in a smooth way. And thank you, Dr. Jose, Dr. Nihas, for staying beside us for continuing this program. And thank you for all the people who have joined for this session. Hoping to meet you all the next month for the next session with an eminent speaker. So thank you all. Thank you, everyone.
Thank you. Thank you. Good night.
Good night.
Good night.
Thank you, sir. Good night.
Thank you, everyone. Privileged to be
Thank
here.
you.